And now the last speaker in the session will be Dr. Iris Fall. She's a trained physician from the University Hospital of Barcelona. She's dedicated to precision medicine and oncology over now 15 years and Vice President of Medical Affairs and Healthcare Partnerships at Guardant Health, and started there in 2016. Guardant Health can be also named as one of the pioneers in liquid biopsy. They were founded 2011 and also were involved in quite a lot of international studies. And yeah, Iris, thanks again for being here. And yeah, we're looking forward to your talk.
Thank you, everybody, for having me. I have to say all the presentations have been amazing, so I would love to follow up with everybody individually afterwards. I've learned a lot, and I think we share a lot of, thinking about potential opportunities to improve patient care, but also learnings about liquid biopsy. So I focused most of the data on colorectal cancer, but they are applicable to all solid tumors. Just in sake of time, you have seen this graph in different versions. Guardant started developing the first assay back in 2012, as mentioned, in the advanced cancer setting, where for lung cancer, sometimes it was quite complicated to get enough tissue, and there were quite a significant number of biomarkers to be tested by guidelines. So the first assay, the Guardant 360 CDx, that is also CE IVD marked and available in the European territory, has been the first broad comprehensive panel approved by the FDA in liquid biopsy, and this can be used in a multi-tumor setting for solid tumors, not for hematological malignancies. But the aim has been always from the founders to move into a complete cancer care and be able to help with blood through the continuum of care. So going through also these earlier stages of disease, minimum residual disease, and ending up in screening. And I will give a quick snapshot about the 3 stages. I'm happy to take conversations after this fantastic meeting. So as Professor Pantel showed this morning, already last year, the ESMO published several recommendations for most of the solid tumors regarding the benefit that liquid biopsy can bring in some settings. And if we think about colorectal cancer, you see the alterations that should be tested before therapy starts, and then if a re-challenge is considered. And it's important to have useful platforms that cover most of the needs. Obviously, the indications are for all solid tumors. I highlighted colorectal because, this was the focus. But any guideline included biomarker is covered by this Guardant 360 CDx gene panel. One of the significant elements maybe is also that several of these genes are sequenced completely. So like ESR1 mentioned by my colleague just a few minutes ago, EGFR, for lung cancer, for colorectal, the RAS mutations are completely sequenced, so you don't lose anything. We also look at amplifications and fusions in the blood. This has been validated, and concordance with tissue findings has been shown. So this was one of the processes to go through the FDA, and we also report the MSI status into here. You mentioned clonal hematopoiesis is something that we filter out with algorithms and artificial intelligence. So I think these points raised during today's talk are very important. And there are a lot of, publications around multiple tumor types comparing with standard of care and also the clinical benefit in including liquid biopsy. They are very complementary, and depending on the situation, the patient and the clinical setting, one might be helpful or the other. These are nice data produced in Europe showing in 155 patients newly diagnosed with metastatic colorectal cancer. They got standard of care procedure at the center, and in parallel, a blood assay was taken to run Guardant 360. One thing that we saw is the turnaround time from blood taken to result of the global panel was a bit less than 10 days. With the Guardant 360, with the standard of care tissue procedure, it was 27 days. And then a positive biomarker finding rate of nearly 90% based on the liquid biopsy. So really helpful in the clinic. Another interesting thing is about the RAS testing. So if we look at usual hotspot testings, the most frequent is to cover the KRAS exon 2 mutations. And these compromise around 80% of the RAS alterations, but there are 20% that we would miss. So through a broad panel, you are able to also capture these other alterations that are not in routine or in some panels, and that would allow you to identify patients that might not benefit or benefit from the anti-EGFR therapy to start with. There already also have been talks about tumor heterogeneity, and when tumor evolves, what happens? And if you have different lesions, how do you capture what's ongoing in different lesions? So this is a very nice publication from Professor Corcoran, showing that at progression, if you take a blood sample, he used Guardant360, or you take a tumor biopsy, you know, taking the tumor, you find less alterations and in a lower percentage of patients compared to blood, because blood is the filter. And in that sense, at progression, you can capture much better the heterogeneity of what's ongoing through a simple blood draw. From the easiness, we take Streck tubes, we provide with kits, it's whole blood. The center does not need to process anything, and it's shipped by FedEx through to the laboratory. We have several now, so that this can be processed there. The other element is to use this. We have seen also some example as a molecular response element. And in chemotherapy, it's usually quite good to look at CT scans as they are planned. But in some areas like immunotherapy, we might have saw the progression on imaging. And if we take a blood draw 3-4 weeks after starting any new cycle of therapy, we can already see in the cell-free DNA and the ctDNA, if there is a rise or a drop or even a complete disappearance, if the patient is a responder or non-responder, and this is related also to overall response rate and progression-free survival. The other element about blood combined with tissue is that in clinical trials, sometimes we don't get tissue from all patients. So if you use a validated blood assay, the enrollment into clinical trials can be much quicker. And this is a Japanese study, Godzilla, where there are all gastrointestinal malignancies included. And the moment they added the opportunity to also analyze patients with Guardant360 CDx, the enrollment rate duplicated. From this advanced cancer setting, where the first assays were developed, they are based on ctDNA that you have discussed, we moved into validating this for minimum residual disease. It also has been mentioned that you need a very high sensitivity to be able to capture disease in blood. So this assay is not looking only at genomics, it's also looking at methylation. So at both elements combined, which has boosted the sensitivity and keeping a high specificity. And if you look at one of the first, projects we did and that were published in 64 patients with colorectal cancer treated with curative intent, we took a blood sample, and the similar curve that you just have seen, the concept is exactly the same, is about the patients that were ctDNA negative had a very high probability of being free of recurrence after 3 years even, but all the patients that were positive, all of them recurred. So in the positive population, everybody recurred. In the negative population, 12 patients out of 49 recurred over time, but 37 were free of disease after nearly 5 years of follow-up. And so one other element is that if you take one single time point in the MRD setting, the sensitivity for one single time point is around 56%. But if you do 2 or 3 time points, the sensitivity increases a lot, reaching 91%. So this is also something we are learning. When we compare this with what is done in routine we do CT scans and we do the CEA marker. But if we look at the sensitivity of CEA and specificity, it's much lower than even one time point with an MRD solution that is validated. So even one time is giving much higher sensitivity and specificity results. We are now validating the data in prospective trials. 2 are run in the US, are ongoing. They are escalation trials based on the result of the MRD solution that we have on the ground, and 2 are de-escalating studies. One is run in the UK, the TRACC study, and the other one is done in Italy and Spain. It's the Pegasus trial that you might have seen. So treatment decisions are based prospectively on the results. The Guardant Reveal assay is also available for breast cancer and lung cancer. If anybody is interested in discussing data around that, please feel free to reach out to me. And we are also validating the assay now in a multi-tumor environment of 17 solid tumor types. If we move to the very early phase, the screening, and these are data just presented at the Digestive Disease Week in May this year, you also have spoken about fragmentomics. So when we move into the screening, we are looking at mutations, at methylation, and at fragmentomics all together. There are algorithms that are applied. The signal varies between patients. So what we report to the clinician is either a positive or negative result for colorectal cancer. And we validated here the sensitivity and specificity. This was based on 20,000 regular population between the age of 45 and 84, no specific predisposition for colorectal cancer, no very recent screening, and no inflammatory bowel disease. So we did, this was US-based. We have data from 1,000 patients in Spain also, but screening colonoscopy is standard of care there. They don't do fit testing usually, and then we compare it with our results. And the sensitivity for colorectal cancer detection has been 83%, the specificity 90%. If we look at stage 1, the sensitivity was 55%, stage 1 and 2 together, 72%. But if we look at stage 2 by itself, it was already 100%, also 100% for stage 3 and stage 4. So in regions where there is a problem in adoption of screening, blood-based solution might be useful. We are now expanding the validation to lung cancer detection in smokers. We are running a large prospective trial, and we are opening up after that for other diseases like pancreatic and ovarian cancer. So also about that, if anybody would like to have a conversation, we also look very forward to collaboration. So it would be a pleasure to continue the conversation.